Hello, today we're reviewing our expectations for tracheostomy and laryngectomy patient and caregiver education from the respiratory therapist perspective. This session focuses on what respiratory therapists are responsible for teaching, how we standardize education, and how we support patients and caregivers for a safe transition beyond the hospital. The goal is consistency, safety, and realistic documentation that reflects what was actually taught. This education is intentionally respiratory therapist led. Our role is central to airway safety, and that includes education. We're working to standardize how we teach, validate understanding, and document education for tracheostomy and laryngectomy patients. We also use tools like smart phrases, PDI-TV videos, and the airway go bag to reinforce learning and reduce variability across shifts and units. Yes, we collaborate with our nursing partners here at ACU Health Medical Center, but we also recognize that there are many travelers, international nurses, and they also have a lot of responsibility as well. This has led to inconsistency. Our role goes beyond task completion. Respiratory therapists assess airway status and bedside readiness, teach critical safety skills, and validate understanding through demonstration or verbalization. Document what was actually covered, and ensure discharge readiness. Education isn't assumed, it's validated, and when there are gaps, we escalate early so they can be addressed safely. Before we talk about education, it's important to level set clinically. Tracheostomy and laryngectomy patients are not the same, and the education is different. Understanding the airway anatomy and implications directly affects safety, emergency response, and how we teach caregivers. We know that tracheostomy patients still have that upper airway connection. It is really important to hone in on that, especially when we're teaching caregivers, because they do not all have the same healthcare background we do. Education focuses on humidification, suctioning, and emergency management. Laryngectomy patients breathe only through the stoma, and the airway is completely separated from the mouth and the nose, and that is critical. These patients must always be managed and ventilated via the stoma, and that message must be reinforced consistently. Education is part of the standard respiratory therapy work and not just an extra task. Respiratory therapists should verify the airway documentation is accurate, confirm appropriate airway-related orders, and ensure routine trach change schedules are followed, and confirm emergency equipment is available. Education should be occurring alongside routine care, not save for discharge day. And when I say confirm routine and trach change schedules, we also need to be thinking of when we downsize our patients, when they're actually eligible for downsizing. Could they potentially go to a cuffless trach? Respiratory therapists are the ones that move that along. Education is a shared responsibility with clear expectations. Our goal is to prepare patients and caregivers to manage the airway safely, recognize problems early, and know how to respond. This education is ongoing and builds over time. It is not a single conversation. Education should begin as early as possible, preferably on day one after tracheostomy placement. However, we know this is not always ideal. Respiratory therapists should confirm there is a tracheostomy education order, and if there's not one, talk to the team and get one placed. Identify the anticipated discharge plan early and collaborate with the care team. This is also going to be very fluid, because understanding whether the patient is going home or has been approved for a skilled nursing facility, or maybe they were denied, or if they go to an LTAC, helps guide the depth and pace of the education. If someone's going home, that's where we're really focusing on, hey, these patients and their families really truly need to understand what is going on. They may be approved for private duty nursing, but that does not mean 24-hour care. So we have to keep that in mind. So how do we ensure and know these things? Well, we consult with our care team. We participate in progression of care rounds, and we also can examine the surgical LDA list that was created back in 2022 and set up group properties to display this relevant information to us in Epic as well. So RTs can use patient lists and the EHR Epic tools to identify patients with tracheostomies and anticipate discharge needs. This allows education to start early and reinforce over multiple days and weeks rather than being rushed at the end of hospitalization. So we've all seen this in our Epic. There is the available list, and if you scroll to where it says ECU Health Medical Center or EMC, that's when you will open that folder. We will not be opening up the ancillaries folder that we normally open up, but just open up the EMC folder for now. So we're going to scroll past that ancillaries folder and scroll to a folder that says respiratory. And within that respiratory folder, we're going to scroll all the way down to where it says surgical LDAs. And we're going to actually create a group or a My List within Epic for us as users, because using respiratory specific lists and airway identifiers help ensure we don't miss patients who require education. These tools support situational awareness and help prioritize education during daily workflows. So respiratory therapists can customize lists to track patients with surgical airways. This helps ensure education is not missed across shifts and provides continuity of care when multiple RTs are involved in the care. So this was established, like I said, back in 2021, 2022, and then since from that point forward, every therapist that has came through and has gone through training with our technical analyst has had this group added within their My List. The assistant managers are also supposed to be ensuring that this list is available for the RT staff and should be looking at this list as well. We know accurate airway documentation matters. Respiratory therapists should verify the LDA reflects the correct airway and the key information visible. This supports safe care, clear communication, and appropriate education. So when you create your My List, you can actually create different properties within that list. And then in the My List editor, if you copy this number within that surgical LDA, you can actually have these properties built in as the expected discharge date, the discharge comments, and then the anticipated final discharge destination. And this is important. And right now in this test patient, this is not the live environment. This is a test patient. In this test patient, you can see that there is a dash in the discharge comments. In a live patient, and I can't put live patient information in here, we all know that, but in a live patient, the case managers in their documentation will actually write if the patient is pending approval for a sniff or if the patient actually has been denied a sniff, and we're able to look at that information very closely. These are the core topics respiratory therapists are responsible for covering. Education includes understanding the airway stoma and skin care, intercannula care, humidification, suctioning, signs of trouble, emergency response, bathing and safety, communication plans, supplies, follow-up, and trait change education when appropriate. Laryngectomy specific education is essential when applicable as well. And just remember that not everybody has a disposable intercannula. Not everybody has a reusable intercannula. There are many different types of trachs on the market. Also ensuring that you utilize the trach mannequin that's on 3 North. We have been keeping that in the 3 North equipment room in the box that it belongs in for over a year now. We have actually purchased 2 mannequins within the department. One we use for training and that can be checked out, and then this other one remains on North Tower so we can utilize it across the hospital for education. Our goal is to ensure caregivers can perform critical skills when needed. Return demonstration is expected for high-risk skills like suctioning, bagging, trait changes. Other topics may be verbalized. Respiratory therapists should clearly document whether understanding was demonstrated, verbalized, or needs enforcement. Does this person not understand? We need to be able to document that appropriately. And laryngectomy education is high impact and non-negotiable, and those patients only breathe through the stoma. Oral nasal airway attempts are unsafe, so an emergency ventilation occurs via the stoma, and their caregiver should know that. Reinforcing this message and ensuring bedside identifiers are present are critical to patient safety. So even when the patient is discharged home, it's probably a good idea for them to go ahead and contact their local EMS group or their volunteer fire department to say, hey, just so you know, my family member is a neck breather. And that is really important for them to understand, and to understand that maybe someone is walking in the home in an emergency and they not know that. So very important. Several tools support discharge readiness, including structured education, reinforcement videos, and airway go bag. These tools work together to reduce emergencies and improve caregiver confidence. So what is an airway go bag for discharge? Every tracheostomy patient should have a complete airway go bag prior to discharge. Currently, the adult respiratory care services utilize a plastic patient belonging bag for discharge. I am not talking about our emergency airway kit. I'm talking about a go bag that we pack for the patient. We did receive approval and funding from the ECU Health Foundation for more durable bags this year to get the plan started, and in the future our department's going to have to take care of that cost. The estimated time of arrival on these more durable bags is still pending, but for now we can still utilize this practice with our current plastic bag and just enforce the why. And respiratory therapists should confirm it's present and ensure caregivers understand what it's used for, reinforce it should go everywhere with the patient at discharge. And that's for discharge. The go bag includes a backup tracheostomy tube, the same size and a smaller size, a mirror, lubricant, disposable supplies, suction catheters, gauze, trach ties. RTs need to review these items with the caregiver and ensure they understand of when and how to utilize them. Typically, we do 3 to 5 days worth of these disposable supplies. That is the standard. That was what was agreed upon nursing, case management, and respiratory care team back in the early 2000s. We have shared with case management leaders that we are being asked to get sometimes 7 to 10 days worth of disposable supplies to certain DME companies, and our leadership continues to have discussion with the case management leadership, as our standard has always been 3 to 5 days. We do know that there are some times that a weekend falls on a holiday, and that's one thing, but we are working together alongside with case management to figure out these issues. So PDI TV videos are designed to reinforce education and standardize messaging. They support learning between respiratory therapists' teaching sessions, but do not replace skill validation. So respiratory therapists should know where to find respiratory specific education videos and how to integrate them into care. This is actually a good tool to have actually nursing do as well, because we need to be the ones to primarily reinforce the hands-on learning and teaching, along with maybe nursing doing some of the care, but the main trait changes, stuff like that, respiratory therapy will be doing. So it's probably a good idea to have them incorporate the video tools as well as us. So where are these videos located? These videos are located under PDI Respiratory Care Learning Card. So Respiratory Care actually recently obtained a PDI TV for our own department. We didn't have one before. Each nursing unit was supplied these, but Respiratory Care has shown a need to have these when the other one is in use on the unit. So we do have one. It's going to be stored in 1 North in the oxygen supply closet. Some units have adopted the Respiratory Care Learning Cards on their systems. Others have not. It is an option for them, but for example, 2 North Progressive Care has adopted it due to the high amount of patients they have, or trach patients they have on their unit. Translation support with the MARTI is available, but that PDI should not remain in a room for a patient. This is our PDI, and our PDI is utilized for our purposes, so it would need to go back to that 1 North supply closet, just like we do with the MRI vent. We take it back down to 1 North when it's not in use. That is where it needs to go. It does have a tracker on it, but we just need to ensure that we keep up with it. It is going to be watched, are we utilizing this or not, as well, to see if we can obtain another cart for the Heart Center and Cancer Center, and or if we need another cart for Children's Hospital. So RTs can guide caregivers on how to access respiratory education videos on the PDI TV. These videos reinforce learning and help caregivers review information at their own pace. So when you turn on the actual PDI TV, it's going to populate this screen. You're going to go to Special Care in the bottom left corner. And once in the special care section, you will see in the middle, respiratory care videos are easy to locate. So we are going to select that and encourage caregivers to watch the videos that match their education needs, especially between sessions. Just know that there are no laryngectomy videos. Unfortunately, our education vendor does not have a laryngectomy video, and that is a contract between the hospital and that vendor, but they do not have one. Also know that on the second page of this learning card is education when it comes to Children's Hospital and children's trach needs. Zach is working with them on that. Another thing is the having your tracheostomy removed. That is important for patients that we are downsizing. So if you have a patient that's in the hospital that we are actively downsizing and or going to decannulate, that video is actually really good for those types of patients so they can see the procedure and understand and know what to expect after the procedure as well. All of those cards are usually, the video is max most 3 minutes, but they are actually very short videos, and they all do not have to be watched at one time. I will have this available as a QR code, like for the scanning of the videos as well. This is actually what is going to be attached within the patient's MyChart when how they look at their Epic when they sign in, if they utilize that. But it also will be printed upon discharge for those patients as well. And these QR codes just provide another way for caregivers to access the education. It's not meant to replace or respiratory therapist education or the validation of that education. It's just to give them another tool. And we also do realize that not all patients and their caregivers use smartphones or have access for the QR code as well. So we will be piloting a smart phrase to improve how we document that education. This approach captures what was actually taught, supports education over multiple days, and separates demonstration from verbal understanding. This means respiratory care would no longer be required to document within the education tab. We're going to leave that for nursing. During this pilot at the medical center, we're going to be looking at what works in the smart phrase and what doesn't. So in the future, if we eventually build it within our Epic flow sheet to improve our workflow, we know what exactly needs to go into that flow sheet without having to go back in and edit and ask for a request. And Epic requests tend to take a little while. So we want to ensure whatever we bring to the table is right and works what's best for the respiratory therapist providing the education at the bedside and what we need to capture. The smart phrase allows realistic documentation. Education is incremental, and this tool reflects that. It improves visibility, tracking, and continuity across shifts. So respiratory therapists should only check topics covered during that session. Document who received the education, note the level of understanding, and identify barriers when education can't be completed. Education builds over time, and this tool supports that process. So the Epic Smart Phrase will be resp trach discharge, and this we are going to implement beginning April 1st with our patients. So starting April 1st, everyone will have access to the Smart Phrase in adult respiratory care and begin to utilize it. So we only need to check the topics covered in the session. We're going to select who performed the tracheostomy or laryngectomy, and then this is a multi-select smart phrase, which means that we can select multiple things. We're going to say who we reviewed the education with, where it was the patient, the family, and the caregiver for that patient, or both. And we're going to select the topics that we reviewed and did they understand. We're going to say if the topics weren't reviewed at all due to as well where there was a time constraint or maybe something else that you need to document in a comment. We're also going to say that the caregiver stayed overnight to perform all care that was prior to discharge, and things like this are decided by a board above us. So for example, patients in adults can be their own primary caregiver, but technically there needs to be a secondary caregiver in case they get sick. That is looked by risk management within the hospital. So we need to understand that these decisions are sometimes made above us as well. And also additional comments that you may have. We're going to repeat and build this over multiple sessions. All of this isn't done at once. You should only do a few things at one time with patients and their caregivers. And this is an example of how the SMART phrase appears in the EHR. The goal is accuracy and consistency, not checking every box, but documentation should reflect reality. And this will allow us to build what we need to in the EHR within a flow sheet within Epic. In the future, the goal is to hopefully have this built and work out the SMART phrase to whatever we request in the flow sheet.
Education follows a predictable
and we don't have to
flow.
do additional
Assess,
requests.
teach 1 or 2 topics at a time. Validate understanding and reinforce with video tools, document, and reassess the next shift. Small, consistent steps make a big difference. When respiratory therapists integrate education into daily workflow, we reduce emergencies, improve caregiver confidence, and support safer discharge. Consistency across the shifts is key.
There are a few non-negotiables. Laryngectomy patients have a stoma-only airway. Education must be validated, and the go bags must be completed, given to the patient and their family at discharge. And documentation should reflect what actually occurred. That means we escalate early when safety concerns exist. Coming soon is going to be this Your Guide to Tracheostomy and Laryngeal Care booklet in English and then in Spanish. This has been a long time project. It's currently with the production team. And a durable go bag discharge for adult patients. Currently, we use our patient belonging bags. And then the PDI TV respiratory care learning cards will be translated in Spanish. Respiratory therapists do collaborate with other teams such as speech-language pathology, case management, nursing, physical therapy, occupational therapy, but we are central to safe tracheostomy and laryngectomy transitions. Standardized education, reinforcing with the right tools, prevents harms and improves outcomes. Currently, our ED readmission or ED admission rate for patients that are discharged with tracheostomy and surgical airways is 30%. That is higher than other respiratory populations, and it could be that those populations such as COPD, there's a lot more of those patients. But the thing is that this has a fairly significant amount of airway patients within Eastern North Carolina, and they are looking at this very closely. So we are trying to get a handle on this, proof that we do have an accurate and pretty good process in place to help prevent these patients being readmitted or ED visits again. So some things to remember is that SMART phrase will go live April 1st at ECU Health Medical Center and Adult Respiratory Care Services. Children's Hospital already has a process for that. Adult side needs to adopt it. And then the more durable go bags is pending as far as their estimated time of arrival. And there are mirrors located on 1 North available for this patient population. Brenda is working on a space to have the durable go bags and the mirrors easily seen for everybody, but they are available. And the thing is that we want feedback. What barriers do you see to consistent education, and what would make documentation easier at the bedside? Your input helps refine this process and improve patient safety. And this isn't just done by emails, this is done by work groups and things that you all see. Please contact us if you would want to participate in a work group like that. There already are several other work groups regarding trach care and education and looking at all these things, but I would really like for other people to get involved. Thank you.